Good. Okay. So my name is Sydney. I've been here for about 3 months at the healthcare resort working under Alex Dietary. And I came from Illinois State University where I've been doing my distance program. And I've been helping with one of the residents' nutrition intervention, and his name's Ramsey. So here's some general information on him, like his name, Stephen Ramsey, and he's 67 years old, about 6 foot tall, and his weight is right around 169 when he was admitted in June 24th. His occupation before coming here was a photographer. His family responsibility is his wife Mariah, and his attending physician has been Carrie Schultz. He lives in A128, and his M&A score suggests that he was malnourished. He has a history of not eating prior to coming here at the hospital, and his BIMS was 15 out of 15, so he's able to make his needs known and talk to us a bit about that. Before coming here, he was diagnosed with quadriplegic, but he's actually tetraplegic, where he can't use 3 limbs. He has a protein malnutrition and a bunch of other things. Ramsey has history of a complete heart block, and a dual chamber pacer was placed surgically on October 2019, and that's kind of where a lot of his issues, medical issues, started, was around then. Recent hospitalization was in April 2020 for his pacer. He had an infection in his pacer with Staph aureus, and recently he was admitted with bowel gas in his intestinal walls and had an incomplete spinal cord injury, and he was discharged June 13th with all that. He also had hypernatremia, likely due to his poor intakes before coming here. That's now resolved. Then he also has severe calorie malnutrition due to his feeding setting. Since being tetraplegic, he was unable to feed himself, and he started refusing food. PEG 2 was placed on May 28th to supplement his calories. And then he also has the intestinal bowel wall gas buildup, in which caused a bunch of constipation, and recently he went back to the hospital for constipation as well, and he was treated with a bowel regimen and antibiotics, and as of a little bit ago, before coming here, it was said to be resolved. Oops, sorry. So here's what we calculated for his energy needs. 25 to 30 calories per kilogram was used to maintain current body weight. And then 1 to 1.3 are a little bit higher protein recommendations, since being tetraplegic, he will be losing some muscle mass in legs due to not using them. And this is going to be important with maintaining muscle mass, is a little bit of a higher protein intake. And then, yeah, basically his muscles are going to break down just because he's unable to use them anymore. Prior to coming here, he was treated with Peptamen tube feeding, and they gave him at 100% of his energy needs. They chose this. We kind of talked to him about this in a discussion with the dietitian there on why they chose this. It was just kind of something his body was responding well to. And it provided all this nutrition, it ended up being 2,225 calories, or 2,250 calories, and 102 grams of protein, and then 1,140 mLs of free fluids in what he was on prior to coming here. Kind of what a PEG tube is. These are considered when a patient is nutritionally intakes are not adequate for a period of 2 to 3 weeks, is what they typically choose this route for. The goal is for the resident to consume about 75% of the estimated nutritional needs before via oral intake before removing the PEG tube, and they want them to consume this for at least 3 days before that would happen. Some things we're going to monitor while he's on a PEG tube are like labs, anthropometric measures like weights, and then also like if there's any intolerances to the PEG tube, if he's not accepting it well anymore, potentially like vomiting or irregular bowels because of it. The primary aim is to avoid further loss of body weight, to correct significant nutritional deficiencies, and to rehydrate the patient. They also want to stop the person from losing the quality of life and regain and no longer be malnourished with the PEG tube. So here's some other things that were present at admission. His teeth were carious and with rough lips. His skin wounds, he had a small abrasion to the left shoulder and then a PEG tube site in the left upper quadrant of his stomach, which he still has. And then he was absent of any infection, like that was all resolved by coming here. So we didn't have to worry about that when he came here. And then he had a clean, dry, and intact dressing over top of that. And then here's some of the labs. He had high glucose and low albumin. Was that July 7th, and then in prior June, his glucose was also high, and his prealbumin was low, which was suggestive of his protein malnutrition. All right. So the study of malnutrition, here's some just background and kind of why we chose the nutrition interventions that we did. The definition of malnutrition is the lack of proper nutrition caused by not having enough to eat, or not eating the right things, or being able to use the food that one is eating, which is also known as malabsorption. And then some causes are inappropriate dietary choices or various physical or mental health issues. And then some symptoms are going to be his reduced appetite, feeling tired and weak all the time, getting ill often, or taking a long time to recover from his wounds and taking a long time to heal, or feeling cold most of the time are some symptoms that you may experience if you're malnourished. The goal with interventions are going to be to stabilize or gain weight back, improve functional status, avoid medical or surgical complications, following the established nutrient intake that meets the estimated needs of protein and other nutrition requirements. Sorry, that printed weird. So some of the recommendations, the RDN should ensure that general health and healthful diet is with 25 kcal per kilogram, which is what we chose to do. And then also 1.25 grams per kilogram are ordered for these patients. And that's based on the nutrition care manual following their guidelines. We fell within both with our recommendations. And then provide nutrition education to patients and family members, like materials that show the rationale for recommended changes. So basically check in with family if we make a change, and kind of explain to them why, and then kind of explain to them the expected outcomes of what we're doing and why we're doing it and what we think will happen because of any nutrition changes we make. The ultimate goal is to respect the patient and family caregivers' wishes, so honor our patients' rights, and they have the ultimate say on what we do. The nutrition care manual does say if to use enteral or parenteral nutrition if patients who are malnourished are not able to voluntarily consume adequate energy, protein, or other nutritional needs. And this is kind of what happened with Ramsey. He was refusing food and not consuming orally what he needed to consume to meet his estimated nutritional needs. And every effort should be made at meal times to help assist them to orally eat their food and pretty much try to get back to where they're able to get off the tube eventually. And then another diagnosis he had was a spinal cord abscess, which is a rare condition that can cause permanent damage to your spinal cord. This abscess is a swollen area under your tissue that contains buildup of pus, which is right here. You can kind of see the buildup, and it happens when injured tissue becomes infected, which is what happened prior to him coming here. Your body's immune system will send white blood cells to help fight off the infection, and the white blood cells will start filling the damaged tissue, causing pus buildup and pus made of dead cells, immune cells, and bacteria. So that's what he had surgery on prior to coming here, and kind of how he became a tetraplegic is due to the spinal abscess. And then like the cause of a spinal abscess is bacteria in the spinal cord. Some symptoms he may have experienced were sudden sharp pain to arms and legs, and then weakness that progresses rapidly and loss of sensation in the area of where the abscess is and like below. Paralysis below the area of the abscess is common, and then loss of control of bladder or bowels, and he also may have experienced fever. So here's some research on what may happen if a patient goes through a spinal abscess and what happens to their muscles. There's several body composition and metabolic associated disorders such as glucose intolerance, which may explain his high glucose that he had, and then is insulin resistance and lipid abnormalities and occurring prematurely after a spinal cord injury. So those are potential things that may result after him having this injury. And there's also a higher prevalence of able-bodied populations in like his body. Within a few weeks or months after his injury, there will be a significant decrease in lean muscle mass in the legs. So that may result in weight loss, since he won't have as much weight in his leg, and that's mainly because of lack of use. And then his body's just going to, kind of explains here, the infiltration of fat in the intramuscular and visceral sites is associated with the abnormal metabolic profiles, and major changes in the body are going to be like they may get type 2 diabetes or cardiovascular disease after the SCI, the spinal cord injury. And then it's crucial for healthcare specialists to be aware of the magnitude of these changes, such as awareness that they may lead to earlier recognition and treatment of metabolic abnormalities. I can't say that word today. And that they may reduce and seen over comorbidities seen over a lifetime of a person with SCI. This also can cause deterioration in the body composition, which is what I was talking about earlier, about how the leg muscle may break down, and this is related to reduced levels of testosterone and GH and IGF-1. Low levels of these hormones can reduce capacity of cellular repair and can lead to reduced capacity for maintaining lean muscle mass and strength. In the first few months after the spinal cord injury, muscle loss may be normal depending on the level of the injury, and this muscle loss will stabilize after a few months. Because of the decreased muscle mass and decreased activity after spinal cord injury, your body may burn fewer calories eventually, and it may be necessary to adjust caloric intake in order to maintain the healthy body weight. So if he were to gain weight after a few months, he may have a lower caloric need because he's not burning and using as much energy. We actually have not seen that with him at all, but that is a potential. But we do see weight loss, which the cellular is needing more energy to repair, and that could be related to why he has lost weight, but we would hope to see it kind of level out here soon if that is the reasoning. Here's kind of just a breakdown of the deconditioning of like your muscles, because the spinal cord injury leads to muscle paralysis, which you're less able to exercise, less physical activity will lower the fitness level and reduce mobility. And then the changes in the body, you're going to have an increased fat storage, but then also less muscle. So that will increase the risk of heart disease and other health problems. So it's important to be on it and making sure he's receiving not too much or not too little nutrition. Further diseases in mobility and function may occur as well. And then you have the deconditioning because of the less physical active that he is. So here's a chart I made on his weight history. So he actually came in with a hospital weight of 217, which you can see is much higher than the weight we weighed him at initially, which was 169. His usual body weight's about 200, and he reports about a 30-pound weight loss in the interview we had with him. The weight goal is to maintain current body weight. When we talked with him, he didn't care to necessarily put the weight back on, but just to stop losing weight. Since he was admitted, he's actually lost 7.8% of his body weight, which is a big trigger for dietetics and nutrition, and something we've been trying to figure out through his stay here. But you can see the graph of how rapid his weight loss has been while he's been here. So some of his weight loss triggers you can see over here, like minus 5.2%, and then it went all the way up to like he lost 9.9% during his stay here. And he's only been here for about a month when that was taken, which is an incredible amount of weight to lose. Some of the reasoning may be related to poor oral intakes, possibly a uranous weight on admission, but even with that, his gradual weight loss, if the 217 was incorrect or his first few weights were wrong, you still see that he's been gradually losing weight, and it's been significant even with that. It also may be related to the muscle mass loss after becoming tetraplegic. So we also decided to request to draw CBC, CMP, and a fecal fat qualitative labs to kind of answer some questions on maybe why he's been losing so much weight, with plans to monitor and follow up throughout the whole time he's been losing weight. The PES statement I came up with was inadequate energy intake related to decreased/low appetite post a spinal surgery, as evidenced by requiring enteral nutrition and to meet his estimated needs, and then his unintended weight loss of 7.8% in 1 month, or the 9% in the month span. So when he came here, we calculated those calories that we had before, and we found a formula, and we wanted to only meet half his needs because he's saying that he's full all the time. So we wanted to make sure that he would have an appetite and would start to eat, because his wife and him decided that their ultimate goal is to get off the peg tube. We chose Isosaurus because it was higher in fiber and he was struggling with constipation at that time. So this was going to help with that as well. And then he also liked the Boost Breeze, so we're giving him that once a day to provide 250 calories with 9 grams of protein The goal was reintroducing food when he came here and decreasing tube feedings in hopes that he'd start eating up to 75% of his meals, if not 100% of his meals. Then we had a treatment update. His intakes decreased to 0 to 50%. Boost Breeze was accepted around 50 to 100%, and we trialed MedPass mixed with milk and Boost Very High Calorie mixed with milk. The resident liked MedPass with the milk, but not the Boost Very High Calorie, and this would provide an extra 300 calories to his diet and 14 grams of protein. At this time, he was also tolerating his feedings overnight pretty well and wished to continue his feedings at night. All right. Another treatment update happened. The rehab requested that the resident lays flat at night, and it was the resident's request as well. And with tube feeding, you have to be at a 45-degree angle because otherwise you're at risk of aspiration. So we had to switch his feedings, and we chose bolus feedings so that he could do them during the daytime and wasn't on the tube all day long. And resident at this time reported his appetite improving, which was a good sign. So here's his food intakes that I tracked for about a month of him being here. You can kind of see that there's almost no pattern. If you drew a line, it would be going slightly up. However, you'd have a good day, a bad day, and then it just constantly all over the place. I did do a mean score and got the average, and through this month he was consuming about 46% of his plates, and the ultimate goal is, the goal was at least 50%, but he was getting 935 calories and 37 grams of protein. He also has his ONS, so he does have supplements, nutritional supplements as well, which I'll calculate into this here. Okay, the next slide. So here you see the nutrition supplement intake. The orange, this one right here, is his MedPass, which he accepted fairly well. We had him accepting at 40%, and then we have the Boost Breeze, which is this gray line, which the Boost Breeze is actually, no, it's just one of them right now, which he wasn't accepting as good, but when speaking with him, the resident said he preferred the Boost Breeze and no longer liked the MedPass, and of course, resident's right, so we went with Boost Breeze, but the total energy he was getting from this was 246 calories, 13%, which would bring his 47% up above the 50%. So he's getting all of the energy he needs based on the information we have about him, and 10 grams, so then the 13%. So again, he's above the 50% in which the energy and nutritional needs that he has. He then switched to Boost Breeze 3 times a day based on what he preferred, and he was getting 750 calories or 27 grams and 27 grams of protein. However, he did not drink all of them 100% all the time. I calculated the mean, so in the time that he was taking this, he was getting about 36% of the nutrition from that, which would be 270 calories and 10 grams of protein, and that's also going to put him above the 50% range of his estimated nutritional needs. So kind of a breakdown, the goal of his oral intake was to be above 50% of his estimated nutritional needs, which is 1,920 calories, which is the 25 kcal per kilogram, or also 960 calories or 38.5 grams of protein. So through his food and his plates, he was getting about 935 calories on average on his time being here, and then 30 grams of protein on average, which is just below what we set for him, but with the ONS, he is getting about 246 to 270 kcal and 10 grams of protein, which then totals 1,185 and 47 grams, which you can see is above what we say he's required to eat. So he is eating enough. So his, based on the information we have, his weight gain is not making sense. Like, it just doesn't match.
Weight loss?
Yes, his weight loss. Did I say weight gain? Sorry. So after admission, he also had a few more labs drawn up. And you see here his glucose is still high, and was high prior, and his most recent ones have him within normal range. So that's one good thing. His albumin is now within normal range. The thing that I noticed the most was his ALT went from 19 to 94 and is now high, and his AST went from 25 to 58, which is within normal limits, but it's quite a bit higher, and the actual 59 makes it too high, so it's at the highest within normal limits. So I kind of dig deeper into that, hoping to find an answer on why he would be losing weight. And he has, so some signs and symptoms that he's had are, he had dark color urination at one point, he's got loss of appetite, he had high ALT, and then increasing AST, which here, like, the ALT is going to be an enzyme found in the liver that helps convert protein into energy for the liver cells. When the liver is damaged, the ALT is released into the bloodstream and levels increase. So that potentially could be an explanation to high ALT is some type of liver damage. And then for AST, it says that the enzyme is used to help metabolize amino acids. Like ALT, AST is normally present in blood at low levels, which they were prior when he first came in. An increase in AST levels may indicate liver damage, disease, or muscle damage. Scientists found that levels of ALT and AST at or above 25 units per liver were predictive of potential cancer risk. So I'm dietary, so I do not have any reason to diagnose it, but it could potentially be a future problem that the doctors may find after further testing down the line. And if it was, I wanted to kind of research what we would do if they ended up diagnosing him with that. So some symptoms were the yellowish skin, tiredness, and then we have weight loss of liver disease. So that was one symptom, one big symptom he's been experiencing. Then you have fever, vomiting and diarrhea, and then you have the dark urine. He also has had abnormal bowel movements, so that potentially is a symptom of this. Pain to the right ribs, including stomach area. I'm unsure if he's experienced any of this. And then tenderness right below, like, his right ribs would be a symptom of this. Further testing that we've done, so we wanted to see if there's malabsorption. So we tested his fecal fat. That did come back negative on like 6 days ago. And then we also want to continue monitoring labs, see if his liver labs go off or other labs, to kind of help explain what's been happening to him a little more. We wanted to test the Hoyer scales. So they were recalibrated, and he did get reweighed. However, when we did that, it just showed that he had lost another pound. So that was not super helpful. The other thing would be consulting with a doctor about further testing for liver disease or damage. Some tests I found after researching would be the AFP liver test and physical examination of the liver, see if it's enlarged. You can kind of just feel around their stomach. Well, a doctor could feel around their stomach and kind of determine if that potentially could be an issue. And then psychiatric evaluation would be another thing to kind of figure out why he does not have an appetite, and figuring out potentially if it's mental on why he's not eating. So here are the recommendations for liver disease. So if in a few weeks, months, however long, if we do find out he has liver disease, here's some guidelines. He would want to consume 35 to 40 kcal per kilogram of body weight, or 1.2 to 1.4 times his resting energy expenditure, which that is higher than what we have him at now. So that could potentially be that he's not, if he has this, he is not eating enough for liver disease, which could explain the weight loss. And then protein is 1 to 1.5. Our protein falls within that, but we could also bump it up a bit more because we have a bigger range. And then a goal of eating like 6 to 8 times per day. And then the majority of his protein from dairy and plant-based sources is what I found when researching about liver disease. And another site I found, which kind of backs it up a bit, is the 32 calories per kilogram and the 1.2 to 1.5, and then more frequent meals, which is what this is trying to say. Things you're going to want to avoid are the alcohol, added sugar, fried foods, salt, white bread and pasta, and red meats. So in the future, if we ever figure that out, these are some guidelines that we could follow. So a follow-up plan, we're going to want to continue to encourage eating meals and snacks, since our ultimate goal is get off the peg tube. We just need him eating more. And another goal, follow-up plan would potentially be trying a nutritional cookie for supplementations, because that's going to be higher in calories and protein. So we could see if you'd like to eat that. And then we continue to monitor weight and hope that we are able to stabilize his current body weight and potentially gain back some muscle in the long run. What I'd do different if I started like back over would be potentially starting at 75% of his estimated nutritional needs via tube and 25% via food and supplement and snack to limit weight loss at the beginning when he was not consuming 50% of his estimated energy needs orally. However, if we would have done this, he very well could have never gotten hungry and started eating. And like just since when he came here, he's like, I'm overly full because of the tube feeding. So that very well could have backfired as well. But ultimately, more information is needed to determine if we're to start over, what we do different. And here are my references. And I have a lot more references. And do you guys have any questions? You looked like you're ready.
Do we use albumin and prealbumin as diagnoses for malnutrition? Why not?
No, because there's a lot of things that could affect those labs. They can like somewhat support it if there's a lot of other evidence, but no.
Okay.
I don't know where I'm clicking to. I'm like out of the video.
No questions?
Yeah.
No? Take any questions. Good talk, Sydney.